Hello and welcome to RIVE Reflections in Veterinary Education. Excited to turn this one over to Catherine this month to tell us what we're talking about today.
Yeah, so I surprisingly, for some reason, had a topic. I think I ask Eric kind of like what the thing is every time, and I'm still surprised every time, so I apologize, Eric. But I didn't really know what I wanted to talk about, but OSCEs were on the list, and I have a bit of a bone to pick with the way OSCEs are done, and so I figured we could talk about OSCEs tonight. So for people who are not familiar with OSCEs, they're objective structured clinical examinations. And they were actually invented in the 1970s for medical school examinations because there was a lack of standardization, validity, and reliability on testing for competence in medical school students. And then they were formally published on in 1975 and have been around pretty used. So obviously used and been around for about 50 years now. There's quite a bit of information out there about them. But what I find really interesting is that the vast majority, at least of people in veterinary medicine that I have run across who run OSCEs, I don't think I've actually read the literature on OSCEs because what they're doing in my mind is not an OSCE. So Eric, I'm going to ask you what you know about OSCEs and how you feel about them and if you do them, and just to kind of give us a little bit of background about your experience with them and other
Yeah,
kind of things.
we ran them at Midwestern University. It was an all-day affair, all hands on deck, every faculty, every staff, everyone was doing the thing. So obviously, as an anesthesiologist, I was involved in that process. And so the anesthesia OSCE was to pressure check a machine. And the original rubric that they had, I didn't like, and I can't remember the exact details, but it wasn't particularly objective, I
Mhm.
felt. Like maybe you could do like some scoring or something like that. And I wanted to have like a checklist, like they did the thing or they didn't do the thing, that you would just watch and then you tick off. And you don't need a high level of competency as the evaluator to do that. Like they did the thing or they didn't. And so we did change to that and use that for the anesthesia system. I think they also had like a gowning and gloving one. I think they had like a basic suturing one. I'm sure there were some like physical exam sorts of things as well. And the students would, it was whatever, 100 students would rotate through all these stations throughout the day. And then there was a requirement for like you had to pass a certain number, you had to pass all of them, I can't remember. And then there was like a remediation mechanism for it. So that was my first encounter with that. So that was only what 5 years ago, 5, 6 years ago. Oh wait, no, it was longer ago. Anyways, and I thought at the time, again with the anesthesia one, I'm like, this is, I think, interesting and useful. It's basically exactly what I did when I would teach the intro to anesthesia course. I always had a lab where they had to do this, and get evaluated on it. And so I think that doing that assessment was valuable. I think it was so the first year we did it, there was no stakes. It was just to try it out. The second year we did it, was high stakes. Like you had to pass or you couldn't
Yeah.
progress in the curriculum sort of thing. And I think that was a bit of a disservice to the students and the process. Although I understand philosophically the rationale, like, I don't know, students just don't perform well in high stakes situations, even with something simple like doing a pressure check on an anesthesia machine. Um, so that was my experience, and I have not thought very much about them since, but I have ideas to share. But that's my experience, and I have
Okay.
no idea now that you mentioned this. I'm like, were those OSCEs? I don't know.
Okay. Okay, good
I
to
didn't
know.
I didn't dig into the literature. I just showed up, and they're like, hey,
Yeah.
do this thing. I'm like, okay.
Mhm.
All right, cool. Bobby, your turn.
I know where, like, we've talked about this before, so I
I know,
know
I know.
where this is
You
going
have a
to go.
head start.
Yeah. So, but what I can tell you, I recall like the first time kind of hearing about OSCEs and the term, somebody said OSCE, and I'm like, what? And then, oh, it's an acronym and it stands for this. And at the time I was like, oh, okay. It's, objective and structured, and I like that. And for clinical skills is sort of like, if you just take the name, the words objective structured clinical exam, I think there's a lot of ways you can interpret or assume that that is. And so my experience is fairly similar to yours, Alex. So I had some colleagues when I was at Florida who were like, oh yeah, we want to start doing these OSCEs because they're more objective and consistent and good, and that's cool, and set up similar types of things like how to place and tape in a catheter and all these types of things. But I know where you're going with this, Catherine. And so I'll be honest with you, I have never participated in a true OSCE, right? Like, so based on what has been published before, and I actually don't know that I know anyone who has.
Yeah.
And so, but we do something OSCE like, but it's not like truly objective and structured on like on clinics and things like that. So I'll let you kind of explain all of it, because you certainly know it better than I do. But I know enough to know I've never actually participated in an actual OSCE. I participated in a lot of things that people called OSCEs,
Yeah.
which are very similar to what you described, Eric, where it's like, here's the, different check. I also, for those like the skills checklist, it's nice to be like, did you do this? Yes, you do this. And then there would be parts like, if they do this or fail to do this, that's an automatic, like you didn't pass this particular skill set, whatnot. But yeah, the sort of bastardization of the term OSCEs is, I think, where Catherine's going to go. So there you go. I've set you up. Tell us what's the problem.
I forgot. I did do that. Like if at the end the anesthesia machine was not safe, you failed.
Sure.
So I forgot about that.
Yeah. So yeah, absolutely, Bobby. And so actually, I think what you describe, Eric, is not an OSCE, right? So I think one of the things that we have sort of done is in veterinary education, and I think in higher education in general, is sort of co-opted these ideas because they sound really good, but then we don't actually research them. We just sort of rely on word of mouth or what other people have done, which is pretty typical because we don't get training in teaching, right? And so why would we think to do anything that would help us along the way in that regard? What I will say is that what both of you have described to me are not OSCEs, they're skill stations, right? So you can test somebody on whether or not they can pressure check an anesthesia machine. That is not an objective structured clinical examination, because that's objective, potentially, depending on the rubric. It's structured, but it is not a clinical skills examination, right? It's a, can you do a specific thing at a specific time? So the OSCEs that I have observed at multiple veterinary programs are very much what you talk about. Can you perform a simple interrupted suture pattern appropriately? Can you pressure check an anesthesia machine? Can you calculate a appropriate dose of a medication? Can you set up an IV catheter set? Can you place an IV catheter? Those are technical skills that we all need to learn and teach. But the clinical examination is about how you clinically reason. It's about how you're interpreting information that you're taking in. And it's about how you are sort of communicating that in a way that people should really be able to understand what's going on in your brain. So it does take a lot of time. And I think the frustration that I have, and some of this stems from some of the work that I did, with you, Bob, not with you directly, but at the institution at Virginia, Maryland, was that it was the same thing, right? There was like this panicked all call for everybody who can help us out. Please come help us with these OSCEs. And it was one of those things where people increasingly resisted doing it because it was so draining, and it was just sort of this repetitive thing that didn't really seem to do a whole lot. The students were really stressed out about it, even though in many cases it was so low stakes because they had multiple times to remediate and go through it. And so to me, it was like, well, what are we doing? Are we just doing this to check the box and say that we're doing OSCEs, or are we really doing something that's meaningful to educate our students? And the conclusion I came to, probably unsurprisingly, was that we were just doing it to check the box. And so, I actually pulled up this article that's really good. It's talking about the objective structured clinical examination, and it was actually published as a guide in the AME guide #1. So the Association of Medical Educators in Europe, which is a really good organization. And so it's part 1 called An Historical and Theoretical Perspective on OSCEs. And there's this line here that says, poorly structured OSCE stations may lead to candidates learning skills to pass examinations rather than to improve their actual clinical performance. And I think what you both have described is exactly what's happening, right? Students do get stressed out because it's high stakes, or even if it's low stakes, our students get stressed out because they tend to kind of run on the nervous side anyway. And it doesn't necessarily indicate to you whether or not they're going to be able to A, do whatever it is you've asked them to do in the moment, because obviously in a simulated environment, it's very different than in the actual environment. But B, it really has no relationship to their ability to be clinically competent.
Good.
Do we all need to know how to pressure check an anesthesia machine? 100%. But doing it in isolation as a single event, disconnected from everything else and understanding why it's so important is not super helpful to us. And so, I wonder why and how this, I guess, for lack of a better phrase, this fad of these what I now call clinical skill stations. I can't really call them in good faith OSCEs. Like, where and how did that get started, and who thought that it was going to be helpful to our students? Because the literature is very clear that it's not the way we're doing them, that it's not. So I don't know if you all have like insights or thoughts or comments.
I have my guesses, but like, my thoughts are there was a big push 15, 20 years ago now, where veterinary schools are being told, you need to show us and document for us that your students are learning X, Y, and Z, right? Like COA visits are coming through. How are you actually demonstrating? Because a lot of times these things were happening on clinics, right?
Mhm.
You come onto the anesthesia rotation, and guess what? Like, we're going to go through a system check, and we're going to make sure you can do all that before you anesthetize your first patient. Like that, I remember doing that as a student. And there wasn't a checkbox. It wasn't like a plan thing. It was just like on the rotation, and then you move along, and they give you some feedback, and you correct some stuff. But that was part of it. And so it was more what you're describing, but not structured, not objective and structured, but like a clinical examination to make sure you're doing the thing. And then I think you have people coming in and say, well, how do I know that your students can do these things, right? How do I know? And they're like, well, they passed my rotation. And they're like,
Yeah.
yeah, we're not sure that's enough anymore. And so the people are looking for something concrete, tangible that I can demonstrate and I can show. Here's the numbers, here's the data that I can present to the COE. So I mean, I don't know that that's where it came from, but in my head, that feels like the timing fit. When because I can remember when I was a resident, students having these booklets with all the tasks that they had to get signed off on, and I'm like signing things. They're like, remember that time 3 months ago when I did that? And you're like, no, sign. And you're like, this is great. Yeah, we're totally nailing it here. And some people or some schools have got online systems for that and automated that. But I suspect, right, that somebody came up with a thing like, hey, I read this thing, or I read the abstract for an article, or maybe just the title, I don't know. Hey, objective and structured. Yeah, that's what we want. That's what we want right here. And it became skills lists. And it's not that even those don't have a place. I think you're right. Like the isolated, like go from next to next to next is a little bit weird. But I could imagine taking that OSCE and putting that instead of just somebody watching it at the beginning of my anesthesia case as a student, be like, all right, here's your checklist. You're getting ready to anesthetize this patient. We're going through this checklist. It's real. Those are the highest stakes I can give you because there's a real patient on the end of this.
Mhm.
And so I think there's still room for those kinds of skills checklists and observations. But the OSCE, right, that I think we still have some objectivity, but it's not structured like that. But like coming through clinics, like talk me through your case. What is your problem list? What are your differentials? Tell me why. Like we're doing those kinds of things, but the pressure or the request to document it consistently in a way that I can recognize as an outsider, I suspect is what has driven a lot of this. And I hear that from folks when we're talking about why are we doing it? Because there are a lot of work, as you described, Catherine. Like it's hard to get people to do it. It's like we really need to do this so that we can demonstrate for the COE that we're doing X, Y, and Z, or whatever it happens to be. So that's my theory.
Yeah, I think that's probably right. That jives with me. Do you guys want to know what I tell the students when they come on rotation about their like checklist things?
Sure.
Do not give those to me. Because
Fair.
here's what's going to happen. It's going to be April of next year. You're going to get a notice that says you can't graduate because
Yes.
Hoff never signed off on your skill. So I am putting that
Yes.
on you. Do not give them to me. You won't graduate.
That's exactly what happened at Virginia, Maryland. It's exactly one of the reasons when I took that position that we eliminated the checklist as a requirement for graduation. They
Oh,
had like
nice.
150 things on the checklist. They only
Yeah,
had to
right.
finish 70 or 60 or something of them. And most of them would do it in like April, right before graduation. And they would give it to somebody and be like, I can't do this. I can't graduate unless you check off these boxes. And so, Bobby's there just checking off the boxes, even though maybe she didn't even observe any of
Like,
it.
I don't even know who this student is.
Yeah,
Here you go, sign
exactly.
it.
Exactly.
Do you go
So
to
yeah,
school
Yeah.
here?
yeah, I think that's really an interesting idea. I wonder too, Eric, when did you graduate from vet school?
2000.
Okay, so you graduated, did you take the NAVLE or did you take the CCT?
Yeah, the NBCCT.
NBECCT. Okay. So
Yep.
Bobby and I graduated when it was NAVLE, right? You graduated in
Ah,
2007, Bobby. I
Yep.
wonder if it is sort of part of what Bobby said, but also because the CCT, which was sort of a written OSCE, right, in
yeah.
many ways, because that was phased out, I wonder if this was sort of a way for the rest of academia to be like, wait a minute, we still need to know if students are able to do these things, and so we're going to institute it. And like many of things that we talk about and steal from education and sort of plop into our own ideas about things, it got bastardized and it didn't actually work out. Part of the reason they got rid of the CCT was because it was so intensive, right? The
Yeah.
the marking of it and the grading of it and the creation of it was so intensive. And so I think part of it too, this evolution from what a true OSCE is to what is now really just a skill station probably has to do with that as well. Even though it still takes a lot of time, it's not nearly as intensive in terms of the amount of time and thought that needs to be put into it. It's much easier to say, okay, one skill station is going to be suture selection station. One skill station is going to be like these very sort of discrete things than it is to do what I have pulled up here in this article, which is basically like the first 18 stations that were recommended by the originator of this particular examination. And it's really interesting because station one is to examine a neck, and station two is asking questions about the examination that was done on that neck, right? So station three is taking history from a patient with abdominal pain. Station four, questions on station three. That's what a real OSCE is about, right? It's taking snippets of that clinical examination, having students do it in pieces that are commensurate with the level of training that they've had, and then asking about that so that they can display to you whether or not they really understand A, what they've done, what they found, and then also convince you that they know what they're talking about when they tell you why they think they found what they found or what their conclusions are from those findings.
Yeah. But they're like narrow snippets so that you
Right.
can make it more objective and structured,
Right.
right? Because I think that's the what we run into in clinics. One, I don't know what cases you're going to get,
Mhm.
and then I don't know which part. Like we might spend a bunch of time focusing on the arrhythmia diagnosis, and then we don't get to the treatment of that, and
Right.
and that's okay, right, in clinics. But at the end of the day, like if I want to have it objective and structured, so I say I carve this out, I make it very, very clear, I want you to do this, and then we're going to ask very specific probing questions, and to try to get to this specific answer, or
Right.
answer the specific question about the student's knowledge. and
Right.
and so it is still clinical, but it's controlled, right? That's the
Right.
difference between
Yeah.
just letting them loose on clinics.
Yeah. And I also think there's a little bit more leeway involved, right? So a
Yeah.
student can do an examination on the neck and they could potentially get the wrong diagnosis. But if they can at least explain to you why or whatever question you're asking them, they could potentially give you the incorrect answer or the less correct answer. But if they can explain their thought processes, you could probably still give them at least partial credit, right? You can't say anything during the examination because it's an examination. But when they come back to do sort of the formative part of it and review where they maybe went wrong, you can say, listen, in this particular station, you did a great job on the examination. You found the things that I wanted you to find. Unfortunately, you just didn't quite make the connections between X and Y. Next time, these are some of the things that you need to think about. But again, that gives you an opportunity to really assess the clinical reasoning and understanding and the application of what they're learning in a way that you can't really replicate in just a skill station. So, if you want them to pressure check, that's great, but maybe there needs to be more about it, right? Maybe they come in and they look at a already completed, put together anesthetic machine, and then they have to go through the process of determining whether or not is actually capable of being safe during an anesthetic event, right? So then, of course, they're going to have to make sure that all the tubes are in the right place and connected to the right things, and that the oxygen tank is connected correctly, and that it's turned on, and that the isoflurane or whatever sevoflurane is full to the right amount, and that the lime container canister isn't like all of the things that are
Or
involved.
better yet, there's like an error and they have the
Exactly, and they
information
have
that
to
they should
find
be able
it.
to deduce
Yeah.
what the error is.
Right,
And then you're gonna talk about, okay, now that you've
right,
identified the error, in the next one, we're gonna talk about what are the things you would do in order to address this? Like what are your
right,
differentials for why you're seeing this waveform on the ECG
right,
trace, whatever.
right. Or
in
why is
my
it
lab
so
lab
important?
exam, that's exactly what I did. I had
Right.
three
Yeah,
machines and set up different errors,
Mhm.
including sometimes no error.
That's exactly
exactly.
right. Yeah. And then it's also like, okay, well, so what would have happened if you hadn't had been able to do this? What might have happened to your patient in this particular
Yeah.
situation if that hadn't been caught? Because that's also really important, right?
Mhm.
So again, I think back to my days at Texas A&M, and we did something sort of similar to an objective structured clinical examination. It wasn't, I don't think, fully this way, but it was objective. It was structured. There were very specific questions that were supposed to be asked and answered. And if you didn't ask the right questions, you didn't get the information you needed to get to the conclusions that you came to. I don't know that the rubric was exactly, right there and right on and all that. So probably wasn't quite as objective as we would have liked it to be, but it was sort of within
Yeah.
a clinical examination environment. So my next question to both of you, I think, is like, is there value in trying to actually do OSCEs correctly? Or do we just sort of say, screw it, and we're going to let everybody go on their merry way thinking they're actually doing OSCEs when really all they're doing is skill stations, right? Like
Yeah.
I'm
Yeah.
curious what your thoughts are on that.
Yeah. Go ahead, Eric.
So I've a thought that's informed by a recent experience. So I was just on locum at University of Saskatchewan, and they had previously done what they call OSCEs, which is to take a routine spay or neuter and run it the whole way through, being observed by someone. And so they realized that that's probably not the right terminology, and so now they've changed it to it's like DEPA, it's like direct entrustable professional activity, which is really, yeah, fundamentally that's what I tell the students. I want you to be able to safely anesthetize a spay, neuter, dental. That's what I'd expect you to do. So I just had that experience. I'm like, oh yeah, like that is if that is our goal, then assessing them, can you meet that goal on that case? Like that's best case scenario. And
Yeah.
if your caseload is such that you can do that, that's great. Like
Mhm.
Bobby said though, like you don't always have control over the cases that come in. But at least there, they have four spays and neuters every single day,
Mhm.
and it's like you know that these cases are coming in, and so you can have it happen. And so
Mhm.
that's where I think I think that would be the goal personally. If you were
Yeah.
to ask me like what do you want the anesthesia rotation to look like at the end? I'm like, yeah, I think everyone should be able to get a spay or neuter at the end of the rotation and run it. And like, can you do it or not?
Yeah.
Um,
But
yeah.
what's the value of an OSCE for earlier? Like you're not going to have a first year doing that. So
Right,
is
right.
there
Yeah, yeah,
value
yeah.
in breaking it into
So
smaller pieces earlier in
yeah,
the
so then
curriculum or?
if you can't do that, or like on ER, you can't dictate your cases at all or anything like that. So how can we get close to that? How can we approximate that in a standardized way so everyone gets like, okay, this is what we're gonna have. Um, I mean, I wonder if that's what like a lot of people are using sim labs for to some extent. Like, I don't know how everybody else uses theirs, but at Midwestern we had an interactive sim lab, and you'd give drugs, and the monitoring machine would change, and so this was a way that like everyone has a standardized experience pre-clinically because we can't guarantee what your experience is going to be on clinics. So I think that it is doable. I think there is an appeal to the idea of getting students to have, sort of a standard sort of situation and whatnot. I don't know the my stumbling block is the utility of the assessment piece of that. Like what do we really need to do in terms of like just assessing their ability to do this chunk? How much do I care if they can do that? And I don't know.
Okay.
Yeah. I mean, my first thought is like, like, I haven't volunteered to help with OSCEs, and like, I would be supportive of like, I don't love the setup of let's have a day, or let's have 2 days, or let's have something where they're gonna go station to station to station, and you're gonna like literally you're gonna place a catheter in this one, and then you're gonna halter a horse in that one, and it's just like it's very disjointed and feels not like I would struggle with that. Like now, if you had be not just because there'd be large animal things, but just because it's like all over the place. It doesn't flow. I do think there's a place for in earlier, like in the preclinical curriculum, to say, hey, are there some areas for certain skills, particularly technical skills, or things for patient safety, like handling, and things like that, to say, can you do these things? Do you know how to tie your knots? Do you know how to do this suture pattern? I think there are some skills that are useful to do. Do I think they need to be OSCEs, or what we're calling OSCEs, or this like high stakes objective, like we signed off on this? No, but I think like what you were describing, what you had done in labs previously, Eric, makes a lot of sense. We have a lab, and then we have, maybe there's a lab assessment where like by the end of this, we have an opportunity for you to demonstrate what you can do. And it's a formative assessment where we can give you feedback and say, hey, this is going really well. We want you to work on these things. And I think it's helpful to have smaller chunks of those pieces before you get into clinics and you're trying to integrate it all together. Do I think it would be good for our students to do like a true OSCE before they got into clinics? I don't know. I'd have to really think on that, because you kind of mentioned like a version of an EPA, an entrustable professional activity, and conceptually, that makes sense to me in my head, right? Like that feels a lot like what I've been doing for years on clinics, where when people are like, I can't grade, but like I know, like if I trust this student, and I actually used to say that, like, would I trust this student to see, like, to manage my own pet? Like if my cat came in, it wasn't like deathly ill, not like, oh my gosh, this needs a specialist, but like was like, would I be okay if this was a student who showed up in the room? And if the answer is no, like we have a problem. Like I shouldn't be allowing that student out into the world for other people. And so there is something to that, like that entrustment. And it's a little bit harder to put your finger on and say, well, because they can do this, because it's an amalgamation of so many skills to be a clinician, that I think with a certain amount of observations, you can get a sense for, right? Is it perfect? No, absolutely not. But I'm like, how do we replicate that? And it is nice to have a structure to it, where we can say, yes, this is predictable, but at the same time, like clinics isn't predictable. And and I don't know that I'm biased, right? Because I've been doing ECC for years, and every student has a different experience. And I still feel like I can get a sense for, not can you manage a blocked cat, but can you manage a case, right? Like, can you think through it logically and appropriately? Not that you know all the differentials. I don't care if you know all the differentials. Those can be Googled. But is your thought process logical? Is it flowing? Does the knowledge, your foundational knowledge, are you allowed to connect that to the next steps? Because everything else you can sort out on the fly. But if you can't make those connections, or if you're making illogical connections, that's where I'm like, this is a dangerous student, right? Like those are the ones that I want to identify. And I'm not sure like a true OSCE would do better than what we're doing on clinics. But here's the one caveat to that is, we do often, lots of places, and I hear people say this, we struggle with the student who is failing or was borderline on clinics. And maybe that's where an OSCE could help, to provide that like safety net for the students who maybe aren't ready, that we can identify them sooner. So I don't know, I'm thinking through it as I talk about it, which is so clearly not well thought out here. So I'm going to stop rambling for a second. And what do you think, Catherine? You've thought about it more than us.
So I actually think OSCEs can be really, really useful in those early years, and precisely for those reasons that you both mentioned, right? So hi, yes, you're very pretty. So I don't know why she's been attached to me lately. So yeah, I think the purpose of an OSCE is to actually find those students who are struggling with that. And it does give you an opportunity to see in smaller chunks and in a little bit less intimidating way whether students are getting it or not, right? So again, going back to this station, these stations sort of build on each other. You start with a neck examination, an abdominal examination on a patient who has pain, go to a neurological examination, a chest examination. Then they have photographs of patients and they answer questions about that. They read a written summary of patient's history and patient's chest radiographs. But you can see that each station is sort of sublet into different areas. So not only do you have the opportunity to see how a student's thought processes are working, but you get to see sort of system by system how well they've actually internalized the information that they're supposed to internalize about that particular system and putting it all together. So in that sense, I actually think that they're quite worthwhile, particularly for second and mostly for third year students, for exactly the reasons that you both highlighted. If they're already struggling in second and third years to make those connections and articulate them in a way that cause you concern, then we can catch them before they get into clinics and do become dangerous and everything's all crazy and you can't really necessarily take the time you need to help those students get where they need to go. On the other hand, I'm not sure that the amount of time, effort, and work that you have to put into it upfront and also in the delivery part of it is worth it. And I think in the end, that is probably what sank them. So if people really wanted to do true OSCEs, it takes significantly more time and energy than the skill stations they're doing. And so they just sort of settled for doing skill stations because it was good enough, but it wasn't like so good that, they had to put all this time and effort into it.
That's what
Also,
terrifies me though about
yeah,
that. I think about how much time and effort and like the just drain that
yeah,
what we do for the skill stations is. And I'm like, okay, multiply that
right,
and try to
right.
get people to volunteer. Because I also would guess what we have called OSCEs, the skills stations, one of the big kind of boons, like the hey, this is great, is I can just take somebody who doesn't know this skill. Here's your
That's
checklist.
right.
Give you a few minutes, make boom, 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 and so I can get anybody essentially to be the
Mhm.
observer, where
Yeah,
that's not going to be true for a true OSCE. Like somebody's going to need a lot more training in order to, be the person on certainly the conversational parts of the OSCE,
yeah.
and then the assessment piece. So I can imagine, yeah, the time, resource, intensity of true OSCEs. Like, do you have, is that in the literature? Like, how much time, like, even just the day, like, how much time does one student spend going through an entire OSCE?
Yeah, so this outline talks about that, and they are day-long things. They go from one station to eight through station 18, and it generally takes, I want to say, 4 hours.
For one student?
Oh, yeah, and they have 30-second breaks in between stations and things like that. So, and obviously they're running, they start one and they're going
Yeah.
simultaneously. Yeah, so that part is terrifying. So I think there's a couple of things that I think there's a couple of ways that you can mitigate that and still get the benefit of an OSCE. And then before I forget, Eric, I want to talk about the skills checklist, right? Because I think that a skills checklist is really probably a good thing to have because it is objective. It gives students like sort of finite, discrete goals, but it's not something that needs to be implemented in the fourth year. That's something that needs to happen in the laboratories as you do in your anesthesia lab, like needs to happen in the laboratories over the course of the first 2 or 3 years preclinically before they get to clinics.
Yeah.
And then people can truly do, like maybe they incorporate into their lab classes, a half day where, okay, we're going to sort of go over some of the skills that seem to be the weakest in this particular class, right? But over the course of the semester, and this is where maybe that competency can actually be competency, is I come in the first day and you do a pretest and you're like, okay, I'm telling you, this is what the Army did, right? We went in the first day, we took a PT test and they
Yeah.
basically,
Where
everybody,
are you at? You
yeah,
you can't, the education needs to be individualized, and you can't do that if you don't know where they're at.
right, exactly. So everybody takes a pretest. So you go and you take your pretest. Well, maybe somebody who's been an experienced veterinary assistant or technician knows exactly what to do, and you check them off that day and they're good to go. And they still have to come to lectures and learn all the stuff, but they don't have to do the skills stuff because they've already done it. And then at the end of the semester or the block or whatever it is you're in, those students who are still struggling a little bit, you give them an opportunity to continue to practice that throughout the semester and then, test out of it at that point. And if at the end of the semester they're still struggling with it, then we have to figure out a way to remediate them so that they can be passed on. So, and I think that's few students, right? There's a few of them.
Yeah.
I think where the OSCE comes in is potentially for those students that we do catch early in the curriculum in that first or second, maybe third, first or second year. So I'll probably up to semester 3 of most programs, where we notice that students are struggling not only in sort of the basic science, clinical sciences, but also in those laboratories and those skill stations and those skill sets. And there's just something not quite going there, right? So I don't think it necessarily needs to be an examination in the sense that it's a summative examination, but maybe it's a formative examination where the bottom 10% of students or that handful of students who are really struggling have an opportunity to go through this and have these one-on-one conversations, and demonstrate to a variety of examiners sort of what's going through their brain at any given time. And then those group of examiners can come together and say, oh, well, the student seems to have a really great grasp of cardiology, but their respiratory physiology is very, very suspect. And then that gives you an opportunity to really sort of pinpoint where it is you need to help that student remediate and make those connections. And then maybe they would be more successful moving forward. it would probably still be a lot of work, but you wouldn't have to worry so much about changing and having as big of a bank of stations because not every student is going through it every year. And so you don't have to worry about compromising those stations. And I think it would be a really nice tool for identifying students early in the curriculum that are struggling and
Yeah.
figuring out ways to kind of pinpoint how you can help them to be more successful.
So it sounds, if I'm understanding you right, you would use it more as a selective diagnostic, right?
Yeah.
Like for
Mhm.
the students that have been identified as, struggling and blah blah blah, we're going to put you through this so we can try to pinpoint
Right.
where your gaps are, and then create an individualized, plan for trying to
Yeah.
get you where you need to be. Uh,
Yeah. I
yeah.
think that would probably be really useful. I don't know that anybody's ever used it that way, but
Mhm.
might be interesting to know if that would work. So
Yeah.
I don't know. Do y'all have thoughts on that?
My first thought was like, well, what about the students who are doing well? They'd be like, I want to go through that. That sounds helpful.
You're more than welcome to go through it.
I mean, is that like an optional thing? Like, hey, I'd like to go through and see how I'm doing with this. And but then it gets into the resource management thing, right? Like, because that would make it more resource, like it would if you only have 10% of the class that has to go through for, like if that's 10 students instead of 100 students, like
Right.
that sounds a lot more manageable. I mean, it still sounds like a lot, but um, if you could demonstrate that that would be really helpful for those students too, like that would be a great use of resources, to try to come up with a targeted, a plan and approach. Yeah, there would probably need to be some effort put into like saying, okay, we're going to try to apply OSCEs in this way, and if you can demonstrate this can really help identify what students' needs are, and support them through that remediation process. Now that because that's the problem with the remediation, right? Like we just go, okay, do this again, and you're like, well, it didn't work the first time, so
Yeah.
I'm not sure. Like, but if you can try to make a diagnosis on like what are the issues, where are the hangups for this
Right.
this particular student. So I think it's a really interesting idea, and I do love. I don't know that we always do a good job of having that individualized approach for students who are struggling. And so, yeah, I think it sounds like a research project that needs to be done, Catherine. Just um,
It does.
yeah. So I do think there's a potential there, for using it diagnostically more than, like as an assessment or evaluatively.
Yeah.
It's cool.
Yeah, I think it is an interesting idea. I think I tend to worry about the amount of effort that we put into the bottom, 10%, or the struggling students. Like, on the one hand, sympathetic, they could probably be successful veterinarians. How much energy and effort are we going to put into that to make that happen? Um, yeah,
Yeah.
that's kind of what immediately came to mind for me is like,
Yeah.
yeah, it could be a lot of time and
It
energy.
is a good question. We
Yeah.
do put a lot of effort, and I'm not necessarily saying that's a bad thing, but we do have to wonder about it when resources are scarce. I also thought of another thing that you had said earlier, Eric, when we were talking about OSCEs, like the OSCEs, in air quotes, but just that performing under like those stressful circumstances, and I think you said something to the effect of, we can roll the tape back, but that they never can perform under pressure. And I'm just thinking, man, if that's the issue, like that's what we're going to ask them to do in their jobs. Like I need you to perform this under
But
pressure or like high
we're
stakes.
seeing that,
I
like
know.
this whole anxious generation thing. Like I'm seeing that on clinics where
Yeah.
it's wild. I don't
And I'm
want to
like,
derail the
if an
conversation to that
exam,
topic, but
yeah,
yeah,
Yeah.
if an exam is too high stakes, but putting a life on the line isn't, like if you
right?
can't handle
What's your
these stakes,
plan?
they
Yeah.
only get higher.
Well, so interestingly, I had multiple conversations with the Office for Students with Disabilities at Virginia Tech
Mhm.
because 20% of our students had some kind of accommodation, which is really high. It's really
Oh,
high.
no, it's 50% here.
Oh my gosh.
Yeah,
Wow.
we have 50 to 60 students a year that need
That's
accommodations.
insane. So, okay, that I'm like gobsmacked. But so anyway, so I had many conversations with them and very early in my conversations with them, I talked about the challenges that I had with understanding why these accommodations or how these accommodations early in the curriculum would set them up for success later in the curriculum for those exact same reasons, right? Like if
Mhm.
an examination is high stakes enough that you're shutting down and you need to have a teddy bear in there, or you need to have earphones with your music going, or you have to have all the questions written down in a certain way, then how are you going to be able to function in a fast-paced, even in a not very fast-paced environment, like a primary care clinic where you're seeing 10 patients a day, which is not, contrary to belief, a fast-paced environment. And so what she said to me, the person that I was talking to, was, I understand your concerns and I understand where you're coming from. However, the type of stress that students feel for an examination is very different than the type of stress that they experience when they're actually in a real life experience. And I think that that is probably true to some extent. But I also believe very firmly that if a student is so anxious about an examination, then A, society is like raising them completely wrong, right? Because they're overvaluing what an examination contributes to their individual worth as a human being on the planet. But B, what are we teaching them by telling them it's okay to be so anxious about this that you have to go get help to overcome your anxiety? We're not teaching them to be healthy human beings. And so I can understand that on the one level, but on another level, it's like, I don't understand it because we need people to be able to function. And I think about it, I'm like, yeah, I mean, exam's a 4-letter word, test is a 4-letter word. I mean, I remember distinctly in anatomy going through an exam and we had to like draw these 3 things out of a bucket and we had to then identify on a live animal that particular structure that you pulled out of the bucket. And I remember very distinctly pulling out it was like one of the extensor something on a horse, and so you had to show it to them. And then they said, okay, well, what's the function of this? And I'm like, oh, it's to flex. And they're like, Catherine, you pulled out the extensor, blah, blah, blah. I'm like, uh,
It's to
oh,
extend.
wait, it's to extend, right? Like, because exam was there and it's like, ah, my brain went completely wacky. Um, and that didn't happen to me when I was in clinical experiences. So I can kind of see that there is a difference there. It's a different kind of stress. But I also think we need to figure out ways to help students navigate that stress in a healthy way rather than just sort
Yeah.
of giving them crutches to lean on. I think there are legitimately students who have severe anxiety regardless, and they do need to be managed in a little bit different way. But I think I went off on a tangent there, but I think
Yeah.
yeah,
We all
the
can.
whole point is that like, yeah, I mean, I think to your point, Eric, I actually don't think we put as much effort into helping those students who are in the bottom 10% as much as maybe we should,
No,
right?
I agree. It's usually done, you
You mean
know.
the
Yeah,
bottom 60%?
bottom 10% in the bottom
No,
10. Oh,
I'm being
yeah,
a
in the
smart
bottom
aleck.
60%. No, but
I'm
seriously,
sitting
like,
there when you said like 50 to 60%, and I'm picturing like a lot of them having similar accommodations, like
yeah,
extra time and that sort of thing. And I'm thinking that's no longer an accommodation. That means the
no,
40% of your class is just getting extra challenge. Like the norm
right.
is now this.
Yeah,
And these students were like, let's see if you can do it double time, right?
right.
Like at some point
Exactly.
you just have to say everybody gets this much time.
Yeah, yeah,
Well, and I
exactly.
think didn't
Which is
you do
actually what
that,
I advocate.
Catherine?
I advocate for
Yeah,
that.
where you're like everyone has like 3 hours or
Yeah.
Yeah.
something,
And then
And
the
but
then
you
students
would
with
still get the
accommodations,
people saying, "Well, I need 4.5,"
I
right?
had
You
one
know, like
person. I
that's what
did. I
happens.
had one person that was like, well, but
I have to
honestly,
get my accommodation.
after the first time, they didn't ask for the accommodation
Oh,
because
that's good.
they were done so quickly. They were like, oh, wait a minute. I don't really need 4.5 hours to answer 10 questions. I can
Well,
actually
I
do
get
it.
frustrated with that too, because if a student has an accommodation that says they get double time, and I go, that's great. I want you to have your double time, but I want everyone to have your double time. That's my thing. So if my exam takes an hour, and you get 2 hours, I'm just giving it to everybody. And then they go, no, no, I get
I need
double
4 hours.
like,
Yeah.
no, you don't get twice as much as everyone else. You get twice as much as I think the average student needs. And
Yeah.
if I've decided everybody should get that, then I should be able to do that.
But that's not
And
how
it's
it
a
works.
genuine thing. I'm not just saying that to be like, fine, I'm going to make the test 30 minutes. I'm
Yeah.
saying, no, literally, I expect, and I have data that supports that the
Right.
average student finishes this in this amount of time. But I think about all the students who haven't gone to the office for students for, disability student services. They haven't gone through to say, hey, I think I need some extra help. And they're just going through and sometimes struggling. And if they would perform better with an extra 30 minutes, just like you would perform better with extra 2 hours, then I want to give them that too. Because now I feel like that's more accessible for everyone. And when you talk to people who are in like higher up in the accommodations, they're like, yes, this is what we want. We want universal design.
Right.
But the system is not set up for that because
No.
the student's like, I need double time.
Right.
No, you're needing more time than I think you should. Like I have it set up, this is the parameters. And so that's this where I've struggled. So now the student, if I give everybody double time, the student who got triple time now gets like 6x time. So their exam now takes 16 hours or something stupid. And
Yeah.
it's just like, what? This is ridiculous.
But I
that's
will
how they do it.
say that one advantage to an OSCE is that you actually are in some ways exempt from those
Yes.
accommodations, right?
Yes.
Because it is a skills-based conversational thing. And so
That's
you
changing
don't
now.
like there are some like if they're specifically written ones or reading ones, then they can sometimes get that extra time. But for something like examining a neck, you're not going to get extra time for that.
Yeah,
You're not.
well, that's changing, Catherine. I am telling you because I have seen more and more. So it used to be they would get accommodations for classroom stuff, double time, and I actually don't have a problem with that. I'm like,
Yeah.
because it is artificial, right? This is
Yeah.
not what it's going to be like on clinics. But when they start getting the accommodations for clinics, that this student cannot work prior to this hour and they cannot work past this hour, not number of hours, not length of shift, but I can't work past 4 p.m. ever. And it's
Well,
like,
but so what I will say to this, and then we're going to leave this because I don't want to say anything that's going to get me in trouble,
fair.
is that means
I
there's
will.
somebody who is not understanding what the
Yeah,
rules are and is not
exactly.
advocating for the profession, right?
Exactly right.
So I would have things come across my desk that would say this student can call out at any time during any rotation for any amount of days and cannot
Penalized
be
for it.
failed for it. And I would say we
False.
need to have a conversation. We have technical standards. All students are given access to those technical standards. And when they apply for this program and accept a seat in this program, they are saying that they feel they are capable of meeting those technical standards. And those technical standards are things that cannot be changed
Yep.
because those are things that you need to minimally be able to do and function within to be able to be successful in this profession. Therefore, what you are telling me as an accommodation is not reasonable because it fundamentally changes the standard that the student would have to meet. So no, we're not going to give that accommodation. And if they and when I pulled that out, they would universally say you're right. Right.
Yep.
Okay. I'm not
Yeah, the
familiar
people in
enough
the
with
main
clinic.
campus office don't
Yeah.
know, right?
They're like, I'm not familiar enough with this. This is really good education for me. This is fine, right? Like,
Right.
and then I would say there are things that we can do to somewhat accommodate that
Right.
student. They could
Yeah.
potentially miss up to call it a day a week out of their rotation and maybe still be considered competent. They're not going to be
Or
great
miss the day and then make it up another day,
or
like
make it up another day, right? But also, like, no veterinary clinic is going to allow you to work 9 to 4, 3 days a week and get paid a full salary. And if you graduate with $500,000 in student loan debt and you're working 9 to 4, 3 days a week on $80,000 a year, we are not setting you up for success in any way, shape, or form.
Well, and again, maybe you can find a scenario for that, but it's not in an emergency rotation.
Right.
And because then they're going to say, well, are there things like, are the cases different, between 9 and 4 than after 4? And I go, yes,
Yeah,
one,
they
and
are.
two, the hospital functions very differently after
Yeah.
4. After 4 p.m., right? Like you don't have access to all of these resources that you might have during the day. Like it is fundamentally different, and this student is not getting the same experience. Oh, they can't come in before this amount of time. Well, our service runs where this particular thing happens at this time. The student is going to miss that entirely. They have, and so, but what happens is, like I'm not the clerkship coordinator, and the faculty member who is young, doesn't know this, and just gets these requests, and they're just like, I guess we have to do this. Like, no, you have to go
Right.
back and say,
That's my
this
point.
actually doesn't work. We need to have a conversation. I don't
Right.
need to know the details of this student's
Right.
request, but I need to say, we need to find another way to meet their accommodations because this is not going to work. I cannot, in good conscience, say this student like met the criteria for this rotation if they never participated in a fundamental portion of it.
Right.
But yeah, the accommodations for clinical they're increasing the number of requests because it used to just be the test length and I need a quiet space and then I didn't get them. Occasionally it'd be one like, hey, this person has a medical condition. They might need to like rest and sit down at a time. Like if you're doing standing rounds, they might be like, yeah, whatever, I don't care. Anybody can have that at any time. But
yeah.
If they need to go to the bathroom, you have to let them. I'm like, are we really? Okay, sure.
Yeah, right.
Not doing this, but okay.
Not the Army.
But now we're getting these like excessive, I got a group together and we did a panel presentation on this, on technical standards and accommodations at AV or AAVMC a few years ago. And we had somebody from human medicine, and we'd come up with a bunch of example cases, and I was going through them with her in advance of the conference, and she's like, well, that's not a good example because that would never happen. And I was like, pause.
But it did.
These are actual examples
Yeah.
from people at different universities that contributed these things. And she's like, you're kidding me. And I was like, I wish I was.
Yeah.
And I was like, I'm glad we went through this here, because if you had said that in front of a room full of veterinarians, like that would never happen. They would have eaten you alive.
Yeah. Yeah.
But this is some of the issues with, we want this objectivity, and we have all these high stakes OSCEs and things like that. And I do think it leads back into some of these issues, versus just saying, okay, we're going to have a lab, and, Dr. Hoffmeister is going to go through these things with you, and we're going to make sure you can do the stuff. And it's a little bit looser, but maybe it's a little bit more realistic, and maybe it feels a little bit better for the students too. There's something about we're going to show up and everybody's going to be there, and it's going to be quiet. We're going to be at stations, and
Yeah.
one, that's very artificial. That's not how life
Right.
works. And two, that's scarier. Like, I think that's actually more stress inducing for the students than just the lab with Dr.
Yeah.
Hoffmeister. We're going to go through the stuff.
Yeah.
I don't know.
Well, and I was just reflecting on this when we did this skill station, basically. Um, I would still get students on rotation that had gone through that process that couldn't do a pressure check safely.
Exactly.
I'm like, all right, so what is this really accomplishing?
Right. Exactly. And that's where that quote that I think I said at the beginning was this idea that, if you're going to do that kind of thing in isolation, that it actually leads them to learning skills to pass a test rather than actually acquire the skill, right? They don't go through the sort of like the building of the new neural network that puts it into long-term, learning, and then they can recall it and actually practice it. So
it's also like, I wonder if it's also like contextual too,
oh
right?
yeah,
Like
100%,
doing it in
100%.
that context is different than in a hospital. And
yeah,
that's
yeah,
really
yeah,
interesting.
absolutely. So I think psychologically it's also very different, but from a neuroscience perspective, it's very different, right?
Yeah.
It's like,
Yeah, you're going to categorize that somewhere else. That goes with
yeah,
OSCEs. It doesn't go with anesthesia in
right,
my organization.
yeah, yeah,
Yeah, because I did that, and then I put a halter on a horse, and then I put a catheter in, and then I came around, and you're like,
and
okay,
there's no
that's in
connection.
my OSCE box, right?
Right. And there's no connection, right? It's just like some thing that's hanging out there that you did at one point in your life that you vaguely remember you had to do to be able to get to where you are now.
I remember being stressed about OSCEs, but I couldn't tell you what any of the stations were.
right. Exactly. I mean, what's the point in that, right? And so yeah, I think it's really an interesting concept to think about. And I know we only have a few minutes left, but have either of you heard of the objective structured teaching evaluation, the OST?
Ooh,
No, I'm
no,
not.
tell me more.
Yeah. So, I think about sort of the skill stations that we call OSCEs, and I'm like, okay, if people knew about objective structured clinic teaching evaluations, they would be like, well, you can't do that. You can't just like right? Like you can't do an OST and just break it down into specific skill stations and say, okay, I need you to grade an examination in this one. I need you to create a rubric in this one. I need you to show me that you can, use the technology in this
Is
one.
that what
And
it
then
is?
well, no, that's not what an OSCE
Oh, okay,
is.
good. I was like,
That's what the OSCEs have
yeah,
become, right?
yeah,
But when you're doing an OST, it's like you actually have to go into the classroom and observe that individual doing what they're doing in an objective and structured way, right? Which you've done a little bit with the FARPET, sort of trying to give them a rubric that's objective and structured, and then give them that feedback in a way that's formative, right? So it is an evaluation, but it's not like, oh, you failed, so you can no longer teach. It's here are some things that you could do a little bit better. Here are some things that you did really well. The next time I come in, I'd like to see you make that improvement. And so to me, that's really the value of
the analogy there. Yeah.
it's and the analogy. And I think if I was to present it to people in that way, I think if people knew more about OSTEs, but if you were to present it to people in that way, maybe that light bulb will come on a little bit more and they'd be like, oh yeah, we really are just doing skill stations, which I mean, okay, fine, but don't call it something that it's not. And don't try to justify that you're doing the right thing when you are clearly not doing really anything that's helpful to anyone other than stressing out the faculty and the students and the staff.
Yeah.
So
Well, but like Bobby said, you are ticking a data point to send to the COE, right?
well,
Like
I mean,
I
yes,
think
and
I
that
think
is very
that cannot be underestimated,
that's fair.
especially, at a new program. Like the more data we could have that suggested that our students were competent, that that has value.
Sure. Okay, we're gonna
Well, it has currency, right?
currency. Yeah.
And so,
Fair.
because,
Yeah.
but you're right though, because if you stop doing this, like everybody's doing these types of things, and if you said, "Hey, we're not going to do any of that," you might struggle. Like with the COE, if you're not replacing it with something else that
Well,
they can say, this is tangible. You can't. I don't think at this point we can go back to the way things were, where you get your grades on clinics and that's sufficient.
no, but I think there are ways to incorporate it from the very beginning of the
Yeah,
program to
yeah,
say,
hmm
we're going to use it in a formative way. It's going to
yeah,
be a way that we can identify students
yeah.
earlier
Oh,
who
I
are
think the COE would
struggling.
be fine with that. Yeah,
And then we're going to make those skills checklists. We're going to put that on to the individual lab instructors and
yeah.
make sure that they have that opportunity to sort of actually observe the students doing the thing. And then
Mhm.
when they get into clinics, and maybe at the third year, we do this like grand day of where everybody has to go through and do all these things. I don't know. I'm still
It
just,
sounds more like a grand week if you're talking
yeah,
about how
yeah,
long that takes to be at least a
just
grand month. I don't
but
know.
I think it's important also, like you pointed out, Bobby, to like connect things, right? So like in one station you're doing an IV catheter in a dog, and the next station you're haltering a horse, and the next station you're doing a jugular stick on a cat, and the next station you're doing like
Yeah,
that's just not helpful to students, right?
no, and that's what I
Not
really like
building their
about.
schema in any
Yeah,
way that's
yeah.
really
No,
helpful
that's
to
what I
anyone.
really like about your description of a true OSCE is this builds on this, and then
Right.
there might be some gaps, but like you can still see how it builds from there. You're going to do the neck exam, and then the next time you're basically taking a full clinical exam potentially and breaking it into its parts and just chopping it up. And be like, okay,
Yeah.
now what? Now what? Now what? But it still can flow. I can imagine that it could flow.
Yeah.
I mean, this is what we do. It's not an OSC, but like I'm thinking about the ACVEC board exam, right? Like we'll do
Mhm.
these clinical vignettes, and like here's the first question, blah blah blah. You answer this, and then the next question flows from that one and
Right.
flows from that one because that is how clinical medicine works. And you
Yeah.
don't just the multiple choice exam might be just pew 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 pew.
Right.
And I think for me, that's one of the reasons it's so much harder
Yeah.
to jump around was like, this isn't how it works. But like clinically going through those cases, you're like, okay, yeah, like I'm primed, right? Like literally my brain is primed. I know what's coming next. I can kind of anticipate, yep, this makes sense. This makes sense. It also helps like when I get a question, I'm like, oh, that doesn't make sense. I might want to go back and see did I
Right.
miss something earlier, but which is good test taking, right? Like it's also what happens in real life. If you get a test result that didn't match, you should go back and double check what you've done before. So I don't think there's anything wrong with that because that context does matter. And that's part of clinical reasoning is taking the context and having things make sense and being able to identify when something is out of place, right? Like that's,
Mhm.
I think, one of the, it's an under recognized skill that I have as a clinician is homing in on that, like, there's a little thread there that is loose and I pick at it and pick at it and pull at it. And then sometimes I find things like, oh yeah, we were going to miss that problem because like, I'm not satisfied that, this doesn't match what I expect to happen. And sometimes it goes nowhere, right? Like sometimes there's no explanation, but there has been on many occasions where I'm like, somebody's giving me a presentation. I'm like, pop, 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 oh, hey, tight. You just kind of glossed over that thing. Can we go back to that? Like
Right.
that doesn't match, right? And so I do think there's something that context is so important for developing clinical reasoning skills. And so if we're teaching them in a way where it's disjointed,
Mhm.
we're potentially not fostering the development of that kind of clinical reasoning, which I think is crucial.
Yeah.
I
Absolutely.
wonder if some people are doing what this sounds a little bit more like in their communication curriculum.
Hmm.
Because like with standardized patients,
Oh,
Yeah.
it's like, oh,
Yeah.
you have the standard, you have this scenario, you go
Yeah.
in, you do this
Hmm.
thing,
Hmm.
you get feedback on it.
Oh,
That
yeah.
sounds a little more like true OSCE.
Yeah.
yeah, yeah, I would
That
agree.
might be the analogy.
Yeah, and I think in that sense, the shortcoming there, well, not shortcoming, but in terms of the clinical reasoning is really that they're looking more at the communication skill than
Yeah,
they are the clinical skill.
exactly.
But yeah, I think it's much
But the
closer to what
format,
a true OSCE might be
yeah,
than
the
what we're
format is much
actually,
closer for
yeah,
sure.
what we're saying are OSCEs.
Yeah.
So, for sure.
I mean, it's really good because neither Eric or I have delved into the specific literature on OSCEs, but neither of us are like champions or like we must, So I think we can be forgiven for just being like, I don't know. Like I
Oh
said,
yeah.
I avoid them just because mostly because they're obnoxious amounts of work for little perceived benefit.
Hmm.
But I do think it's a good reminder too that when those sort of fads come out and the cool new acronym comes out, is not to just take it at face value. Like, it's
Simulation
not gonna work.
labs.
Yeah,
Arg.
yeah.
Learning styles.
But to just like take a few minutes even just to do a quick Google search and see what
Yeah.
comes up, right? You know, and it's easy, we get busy with certain things, and so sometimes like we're not going to do that every time, but really to start thinking about it and asking ourselves, you know, critically, because in clinical medicine I'm going to do that, right? Like if
That's
somebody's like,
exactly
hey, this
right.
new drug came out, and I'm like, I guess I'll just start using it.
Right.
No,
Right.
I'm
Right.
going to read up on it. I'm going to look into it. And with teaching, I think we need to kind of raise the bar a little bit for, you know, what we adopt in the same way. Anyway, yeah, evidence-based education, you know, is, you know, for me kind of akin to the evidence-based medicine. We can't always do it, right? Sometimes there just isn't evidence and we go out there and we do our best. But when there is evidence, we should probably look at it.
Yeah.
Yeah. Anyway.
Agreed.
Yeah.
So, well, thanks you guys for a great conversation. I wasn't sure we were going to have enough to talk about when I picked
I'm
this.
never worried about that with this
Obviously,
group.
we did. So,
Yeah.
if
And
you are,
we learned some stuff.
Yeah,
yeah,
for
if you
sure.
all are interested, I can send you. It's an 8-page
Please.
paper or 11-page paper. I can send you the
Yeah,
Amy
please do.
guide, part 1. It's pretty interesting.
Yeah,
And
that'd be
I
great.
think I'm like reading through this and I'm like, maybe it's just me. Maybe I'm crazy and I really I've mislabeled this and I've got this mixed up in my head. And then I read this article. I was like, nope, it's not me.
Good.
Nice.
Which was nice.
Because that would have been an awkward podcast.
That would have been a very awkward podcast. But, fortunately, it did not.
We're going to not publish this one.
Right. Yeah.
Awesome.
So thanks. Great conversation.
Awesome. Thank you.